Welcome to Week 8, the care environment. This week we'll be exploring the care environment and focusing on the context of how care is delivered. Make no mistake, this will not be your ordinary sit and listen presentation, so feel free to ask us questions and above all, have fun while we learn.
I can't do this all on my own. No, I know I'm no Superman. I'm no Superman. I'm no Superman.
Ladies and gentlemen, allow me to present Man Not Caring.
Ladies, hate to disappoint, but my quota for women who bug the living bejesus out of me has been met for the next billion years. Now, Mrs. Wilk.
I'm a Jehovah's Witness. I can't get a transfusion. We believe that blood should not be passed from person to person.
Well, I'm a doctor, and we believe that without surgery, a patient in your condition can suffer from a major case of deadness.
The person-centered approach was devised from the humanistic approach to psychology by one of the founding members, Dr. Carl Rogers, who was an influential American psychologist. This approach was Dr. Rogers' own take on understanding personality and human relationships. The person-centered approach is applied to many different industries. Some examples include psychotherapy, counseling, education, nursing, and healthcare. In psychotherapy and counseling, the title of person-centered approach changes to client-centered therapy. For education, the title changes to student-centered learning. And finally, for nursing and healthcare, there are two titles, patient-centered care and person-centered care. These are used interchangeably, but all of the above titles mean the same thing, to put the person first. Here we are going to discuss person-centered care in the nurse's setting. What does it mean to have a person-centered approach? You know that you have a person-centered approach when the well-being of your patient comes before the tasks you have been given to undertake. For example, the patient's observations. The first thing you need to do is acknowledge that your patient is vulnerable and uncomfortable. Then work to change the way they are feeling by talking with them casually. For example, talk to them about how they traveled there, and being real as opposed to being the nurse, someone of power looking down upon the patient, as this is intimidating and will have inverse effects. Active listening is also a big part of patient-centered care. Active listening skills include using nonverbal and verbal communication. Some examples of nonverbal communication include smiling, maintaining appropriate eye contact, mirroring, so mirror how the patient is sitting. For example, if the patient leans over to put their face in their hands, you also lean forward. This offers comfort and support. Don't get distracted by something else that is happening around you. This could also be fiddling with your hands, hair, fingers, clothes, etc. And be mindful of your posture. You don't want to be slumped in your seat or too erect. Verbal communication skills include remembering, clarification. Often an appropriate pause will arise where the patient doesn't know what to say or is mentally stuck on something. By asking for clarification at these times, it can prompt them to continue. Questioning. Try to hold your questions until the patient is finished speaking, as this may distract them. Reflection. Positive reinforcement, not too often as this may be distracting, and summarization of what's been said.
I'm no Superman.
The key contributors to the care environment are power sharing, the physical environment, potential for innovation and risk-taking, effective staff relationships, a supportive organisational system, the appropriate skill mix, and the shared decision-making system. So what does this mean? This means that we have to think about the whole care environment. Everything in it has a purpose and a place. The physical environment has to be functional and inviting, not like your weekend B&B, but it needs to hold some warmth and comfort so patients feel comfortable within that environment. Staff need to work well together and have an effective relationship within the team. If there is conflict, it will affect the patient's care. This also translates into power sharing. If a staff member is trying to exercise their need for dominance over another team member, then that team is going to become out of balance. There needs to be a non-dominant, non-hierarchical relationship in existence that does not exploit the individuals. Staff need to be concerned with achieving the best mutually agreed outcomes through values, goals, wishes, and desires of the patient. This directly relates to the shared decision-making system. The shared decision-making system is about the organisational commitment to collaborative, inclusive and participative ways of engaging within and between teams. Patients are less informed and involved in decision-making about their health care than they would like to be. However, with person-centred care, shared decision-making can improve satisfaction with care and leads to better quality decisions. Also, better informed patients make different, often more conservative, less costly choices about treatment because it is thought that information provides a realistic appreciation of likely benefits and risks of treatments and enables decisions about potential outcomes in a more considered way. Person-centered decision-making holds central the knowledge and experience that each person brings to the care situation, and it is necessary for decisions that will best serve the patient's well-being. This then has a direct effect on the need of an appropriate skill mix in the team and the organisation. There is no point in having a hospital or team full of nurses who are bound by their scope of practice of not being able to diagnose a patient's condition. The patient would never find out what was wrong with them, so it is extremely important to have the correct people in the client's team that meet their care needs.
The point is, sometimes what's best for this hospital is what's best for the patients. I know it, you know it, and guess what? Dr. Cox knows it too. Although damned if he doesn't disagree with me just because I said it.
I'm no Superman.
312 times 481 equals. Sir, it's not giving me the answer.
It's a typewriter, you jackass.
Oh, God, it's got my tie.
Budget constraints are an ongoing challenge within the healthcare sector of Australia today. They affect many elements of the healthcare environment, directly affecting the quality of care received by patients. Challenges that affect a patient's physical environment include affordability, physical safety, an understanding of cultural safety, and a managerial system in place that is willing to ensure these needs are met. The physical environment also includes the way staff and patients feel emotionally as a direct result of their physical environment. This includes how they are treated and accepted during healthcare practice and delivery. Achieving an appropriate skill mix can prove difficult in a real-world setting. Contributing factors to this include a lack of availability of skilled workers. For example, nurses who work in palliative care not only need to possess the appropriate theoretical skill knowledge, but also need to possess a very high level of interpersonal skills due to the incredibly sensitive nature of their job. When crucial staff lack an appropriate level of developed interpersonal skills, it not only has a negative impact on effective staff relationships, but also on the quality of healthcare that those staff members can provide to the patient. The quality of staff relationships within an organisation directly affects staff members' ability to adequately contribute to the power sharing and shared decision-making elements of person-centred care. When staff relationships are poor, it presents a challenge in providing quality patient-centred care. Such challenges arise when staff members have an unwillingness or inability to build and conduct effective staff relationships. Key components that may be lacking in this respect include the understanding and use of intra- and interpersonal intelligences, micromanagement rather than leading, and displaying impatience and negativity. An innovations challenge faced by healthcare in Australia today is the relatively effortless access and digitalisation of online health and medical resources. While academically trained medical staff have easy access to this goldmine of information, so do their patients. Often loaded with only the knowledge of their symptoms, patients head straight to Dr. Google and convince themselves of an accurate diagnosis before they have even made an appointment to see a healthcare professional. This can trigger an unnecessary state of distress for the patient, making them harder to assess and treat. Healthcare professionals must be mindful of the effect this has on patients in order to adequately participate in power sharing of the person-centered care framework. Healthcare professionals sometimes fail to acknowledge that whilst they may be academically and medically trained, nobody is as competent in knowing their symptoms as the person experiencing them. Healthcare providers work under a system of management which dictates the manner in which healthcare is provided. When challenges or issues arise within this scope that are out of the staff member's control, staff and patients present these issues and concerns to management for resolution. Issues relating to this that present in a real-world practice include staffing volume and skill-based availability, interpersonal and professional issues among staff, adequate timeframes allocated to staff to perform specific tasks, and a lack of accessibility to equipment required to perform specific tasks. The ability and willingness of management to resolve such issues have a direct impact on staff and the quality of care that they can provide to patients.
I'm no Superman.
The care environment, focusing on the context in which care is delivered, is an important part of person-centered care. In the emergency department, patients present with various concerns and are treated according to urgency. This is called triage. The Australian Triage Scale states the following: a scale of 1 must be treated immediately. A scale of 2, treatment must begin within 10 minutes. A scale of 3, treatment must begin within 30 minutes. A scale of 4, treatment must begin within 60 minutes. And a scale of 5, treatment must begin within 120 minutes. However, emergency departments are often overcrowded and are notorious for long waiting times. How many of us dread going to the emergency department because we know we could be waiting hours before we will be seen by a doctor? Aggressive behaviour from patients may be associated with extended waiting periods to see a doctor. Patients who have concerns about their health and are forced to wait contribute to aggressive behaviour reports. The introduction of nurse practitioners to the emergency department has been a nurse-led initiative to combat the extended waiting periods for patients presenting to emergency departments in Australia. Nurse practitioners are highly skilled, experienced registered nurses who have completed a Master's in Nursing. They are qualified to refer patients to other healthcare professionals, prescribe medications, and order diagnostic investigations. Nurse practitioners provide flexible healthcare delivery that complement other healthcare providers. Nurse practitioners in the emergency department can assess and treat patients presenting with a number 4 or number 5 on the Australian Triage Scale. This allows for doctors to focus on the more urgent patients presenting with a number 1, 2 or 3 on the Triage Scale. The introduction of nurse practitioners has helped reduce aggressive behaviour in emergency departments by decreasing waiting times. Time management has improved, and nurse practitioners assist budget constraints by reducing the number of doctors required in the emergency department. This initiative relates to the care environment by ensuring an appropriate skill mix is present. Patients are seen by a healthcare professional who has the skills and experience required to treat the patient's concerns. This initiative is also inclusive of supportive organisational systems. For example, the employment of nurse practitioners, decreasing waiting times, support both the patient and employees within the organisational system. Sharing the power is demonstrated by nurse practitioners and doctors redividing the original doctor workload, enabling all patients presenting at emergency departments to be seen by a healthcare provider qualified with the skill mix required to assess and/or treat the patient's concern within a shorter time frame.
Overall, we hope you have enjoyed this presentation and that it has broadened your knowledge of what a person-centered care environment is and the challenges that are associated with it. We now encourage you to click on the Think tab and answer a few questions
that relate to this presentation. And if you want any further information, there are extra resources in another tab that has a range of links. Also, if you have any questions for us, please feel free to post them in the Discuss section. Thank you for exploring this topic with us.
I'm no Superman.